This is LiveWell Talk on comprehensive health care in family medicine. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Family medicine is about more than treating an illness. It's about caring for the whole person through every stage of their life, from preventive care to chronic disease management to mental health, as well as overall wellness and comprehensive care. Family medicine clinicians help patients stay healthy in the long term. Today we're talking about the whole person health, what that really means, and why having a primary care clinician matters. Join us today is Dr. Lauren Hall, a physician at Unity Point Clinic Family Medicine, Mount Vernon. Dr. Hall, welcome.
Hello, thank you for having me back.
When we say whole person, it's kind of a generic term. It's kind of ambiguous. But what does that actually mean to you in your practice of medicine?
It's a very complicated question with complicated answer that is probably going to be different depending on every person and patient and practitioner that you ask. I would probably break it down to three different things. One, that problems are usually multifactorial, meaning they are intertwined with other problems. For example, if someone comes in with high blood pressure, they could have high blood pressure. They could also have knee pain, so they're not exercising anymore, and they're taking a bunch of NSAIDs like ibuprofen, which raises their blood pressure. So I think taking the time and trial and error to figure out what is going on and the treatment plan. It's just an important concept for people and practitioners to be aware of. Second, I'd say focus on prevention and lifestyle. I think most medical problems do have some sort of basis in our daily behavioral pattern. For example, strokes, heart attacks, diabetes, high blood pressure, some of all the most common diseases that we see have a big basis in daily patterns. And then a third would be like when the patient is in front of you, what do they need? What is their goal? Asking the why. For example, with weight management, a lot of patients will have a plateau in their number. They'll see that number, they'll get really frustrated. And I kind of try to redirect their goal. So, well, why are you trying to lose weight? Some people say it's to be healthier, so they can move better to play with their kids, or so their clothes fit better. And maybe the number stays the same, but they've achieved some of those other goals. And so it's important to kind of ask more questions about the why.
One thing that's worked for me, I think there's two types of patient-physician relationships, fraternal and paternal. And there's a patient that they really just doc, just tell me what medicines I got to take. I trust you, just do it. And then there's another patient that really wants to be involved in that decision-making, which is very rewarding for the clinician, right? But I think you've already mastered it where you can tell the difference between when you're sitting with that patient, just what sort of relationship are they looking for. But family medicine, one, is huge. The spectrum of just, compared to the different problems that will come into your office on a daily basis are so wide. But, Mount Vernon has a great reputation as a clinic. Tell me some of the things that you guys do down there that make it so special.
I think we have several providers. We have four physicians, 2 physician's assistants, and then a nurse practitioner as well. So we all come from different backgrounds. We all have different clinical interests. For example, Dr. Stein and I do a lot of women's health. I do a lot of weight management. We all do all of this, right? But I think we each have our own special area that we are skilled in. So not only can we provide that to our own patients, but say we do have a question, we can always go to the other providers. We work really well as a good team. And then our support staff is amazing. And I mentioned in a prior podcast that we don't have any urgent cares nearby, so we often are able to work patients in the same day and see acute concerns.
I've always found that so rewarding, to see patients, they have a problem that day rather than, it took them forever to get into the clinic. And I think we all strive to have the access we possibly can. Family medicine, primary care, general internal medicine, general pediatrics, it's become so transactional. The days of the family physician or the general practitioner taking care of everything for the patient has really changed. Urgent cares, express cares, the internet. How do you have all that coming at you? How do you synthesize that and kind of develop treatment plans based on that?
I think first we do the best we can with the information we know at this exact moment. We follow evidence-based guidelines from our leading bodies. For me, that'd be the American Academy of Family Physicians, but we also take our data from the specialist groups like ACOG, which is gynecology, or the American Cancer Society for screening tests. But it is a lot of information, and it's impossible for any one person to know all the information out there at any one point.
Right.
And so it's very important that we rely on our evidence-based medicine in those moments, because the last thing we want to do, there may be some new fancy thing that's popped up on the internet that helps a patient with a certain problem. For example, I had a patient ask about these special boots that they had seen on TV for neuropathy. The problem is that that treatment had not been proven to be effective, and I would hate for the patient to spend a lot of money and time and energy on that, and then it was not helpful. And so that's why we rely so much on our evidence, is to make sure what we're doing is safe, effective, and not hurting someone.
Yeah, I think famously in 1996, I said I thought the internet was a fad and would probably go away, which has proven to be wrong. And I freely admit that. But there's just so much information out there, Instagram, TikTok. You see it all the time. And it kind of goes back to the colloquialism. If it's too good to be true, then it's probably not true, right? Do you get a lot of that into your practice? Patients coming in with maybe ideas that they've gotten off the internet, or something they think that's going to work for them, and how do you just in the short time I've known you, I totally know you build a trust account with your patient, and that's quite easily but how do you work that into evidence-based practice?
Sure. A couple different strategies. One is I try to keep an open mind, because there may be things, again, that I don't know about that are helpful for my patients. So I try to if I don't know about it, I tell the patient, look, I don't know a lot about this. I'll try to find out for you. I try to make sure it's safe. If they are going to do it, I want to make sure it's not harmful. Often I cannot answer the question of efficacy, because often there's limited data, but I think going to that first thing is it safe? If it's safe and it's not costing the patient a lot of money, I think it's reasonable to try it. But what I really emphasize to patients is that if they're going to do something that has not been proven to be effective, or for that matter, any treatment that we recommend to make slow changes, make one change at a time, and then carefully evaluate over the next few weeks, was that change helpful? For example, that new supplement that they started, have they noticed any side effects? Have they noticed that it's doing what it said it was marketed to do? And so trying to work with patients to make sure that we're carefully evaluating things that we have limited evidence for is, I think, the strategy I usually go with.
That's some great advice. Start with safety, start with expense, and then kind of take a look at the risk and the benefit and move forward. When we talk about preventive healthcare, you'd indicated previously that was of interest to you. On an average day, what percentage of the patients are you focused on preventative care, and the others is some sort of acute problem? And it's probably 100% both, right? Because every problem. It's
exactly 200% at all times. So I think most of the time when patients are coming in, they are coming in with a concern, so an active problem, not prevention. That being said, prevention, I would argue, is more important, but it does get less attention for a lot of reasons. And so what I usually try to do is, when a patient is coming in with a concern, we try to address that concern, but then I'm always looking at or thinking about their preventative care, and if there's any changes or updates we can make that day, or making sure they're scheduled for their annual physical exam, which is an appointment that is dedicated for preventative care. For example, your mammograms, colonoscopies, pap smears, vaccines, things like that.
Yeah, and then Medicare has an annual wellness exam, correct? Tell me about that. What is that?
So the Medicare annual wellness is similar to an annual physical exam in that it's focused on preventative care. But once you are a Medicare patient, there are some assumptions that you are usually age 65 or older. And so they really want to make sure they're focusing on some age-specific screenings, for example, cognitive decline, falls, and medication side effects or medication interactions. So there's often a large questionnaire associated with the visit that we want you to fill out, or that insurance has you fill out, that screens for a lot of these concerns. But at its root, it's similar to an annual physical exam where our focus is preventative care rather than managing new or chronic medical conditions.
Okay, that makes sense. Vaccine hesitancy. I mean, we probably could do a whole podcast on that. How do you people come in with the hesitation with the vaccines? How do you have that conversation with a patient?
There's a lot of different ways to go about it. Some more evidence-based than others, but I would say I try to come from a place of understanding. I think it's important just to recognize where the patient is coming from, that they are trying to make the best decision for their health, and usually their child's health is where this comes up most, since most vaccines are given in childhood. But once that is established, like I say those words to the patient that I understand you're trying to make this best and safest decision. I think that takes down a lot of walls. And then from there, I try to build trust and talk about the evidence and talk about their concerns. And we ultimately can never force, and we don't want to force a patient to ever make a choice about their care. And so we just have conversations. Yeah. And if at any point they are interested in vaccines, then we can give them.
Yeah, I think that's very sound advice for that. It's always the risk benefit,
exactly,
that you take. You've spoken about treating the whole person, the comprehensive health care. I think mental health doesn't get the recognition that it should, particularly in the primary care. It's just as, you have diabetes, it needs to be treated. If you have stress and anxiety and depression, it needs to be treated. So what's your approach to mental health? What are perhaps even some misconceptions that you think people have about mental health? And how do you approach those patients? Mm-hmm. Because they seldom walk in and go, I'm depressed or I'm anxious. They come in with other issues, right?
Often issues of sleep, changes in weight, either up or down, heart concerns. So they're having a racing heart from stress, and they may think there's a primary heart problem. So we try to first I ask the patient what in their perspective is going on in their life. And then two, we do want to try to rule out medical conditions when we're suspicious of them. I have we can check the thyroid. It's very, very rarely is a thyroid issue, but it's important and reassuring to the patient and the practitioner that there is not an underlying medical concern that we're missing. And then from there, we go to treating mental health, and that the foundation for treatment is counseling. And I think one really common misconception that patients have about counseling is that it's just talking. It is not. It is evidence-based cognitive behavioral therapy of some format, usually, which means working with a licensed and trained professional to reframe or rewire the brain to better manage stress and to develop coping mechanisms so you have fewer symptoms and hopefully will need less medication or potentially no medication at all, which leads to the second misconception. A lot of patients are requiring or do find benefit from medication in addition to counseling. And one of the biggest hesitancies is that once they're on medicines, they will be on medicines forever. For most mental health concerns, which is statistically major depressive disorder or generalized anxiety disorder or a short-term stressor that's going on that's causing these, patients don't have to be on medicine lifelong if they don't want to be. It's safe to be on medicine long-term, but generally speaking, if you are doing counseling and you do medicine for about a year, we can consider tapering at that point and seeing if we can get to lowest effective dose or none at all. Some other mental health conditions that are more that are more long-term, for example, like schizophrenia or bipolar disorder, they often will need medicine longer term.
Right.
But I would say the majority of patients, there's usually some sort of situational stressor that is making the symptoms, causing symptoms to be bad to a point where they're interfering with daily life. And once that stressor passes, or you go to counseling and learn some coping mechanisms, we can decrease the medicine.
I always found one of my highlights of a day in clinic would be when I discovered or helped a patient get off of medicine.
Yes, that's one of my favorite things.
Isn't it though?
Yeah.
I mean, you're like, they've been taking this, like, well, hey, that always kind of made my day. I always felt,
I love tapering PPIs. That's my favorite.
Yeah. There was a time in hospital medicine that everybody got placed on a PPI for stress ulcer prophylaxis. Totally not evidence-based. We know that stress ulcers do occur. There's a specific patient population that's at risk, but everybody got placed on. And, so then they go home and they would come to the hospital service, and then, they see their family doctors 6 weeks later and say, well, why are you on this? They put it on the hospital. And then they'd say, well, stop it. And if you don't have any symptoms, then let's just stay off it. Well, they'd stop it, get heartburn symptoms.
Rebound, yeah.
And then call the doctor back and say, oh, yeah, man, I have really bad heartburn after. Oh, well, then stay on it. And then it's 10 years later. But there's a small British study. It was females, healthy females. They just gave them PPIs for, no reason, and then stopped them. And they all had rebound symptoms. Yep. So that's so interesting that you've experienced that too with patients, that you can take them off, but you have to taper it because they will get rebound. When it comes to the preventative care and primary care, used to cover the from the settlement in Tama, the Meskwaki Indians, and I used to do an outreach there, and they would not come to the doctor if they weren't sick. And you would call them and say, hey, you had an appointment today to follow up on your kidney disease. And they're like, well, I'm not sick. I said, but I still need to see it. They would always come. I mean, they always, I'll be right over. Sure, no problem. But, so tell us your philosophy or what you could counsel patients on. Doctor, it's not just for when you're sick. There's other reasons to have that contact with your primary care physician.
One, you're going to get sick of me saying this, but one is prevention. So a healthy 25-year-old comes into me, they have no chronic medical problems, and maybe they are leading a fairly healthy lifestyle pattern, but I've seen a big uptick in vaping in our 20-year-olds. And so I will talk to them about, let's try to cut down on that. Let's stop. And some of them will, some of them won't. But for the ones that I did get to stop vaping, we may have prevented reactive airway disease, COPD, lots of other problems down the road. So one is prevention. And then two would be early detection of diseases. For example, diabetes, kidney disease, high blood pressure. All three very common. All three can lead to really we call it high morbidity and mortality. So it can end your life early, and it can also make it lead to a poor quality of life. For example, chronic kidney disease could lead to kidney failure and dialysis 3 days a week. So when we can detect those diseases early, we can prevent them from becoming worse or having that high morbidity and mortality. And those three diseases in particular are often asymptomatic, meaning patients have no symptom. They don't feel that they have them. And so they'll say, Doc, you say my sugars are high, but I feel fine. Why do I have to treat them? And having that conversation with patients can be very challenging to all get on the same page about why it's important, but is in fact very important for them down the road.
At one time, I had learned that it was like the type 2 diabetic. They've had it for 4 years by the time it's diagnosed. Was on average. Is that still
something? I'm not sure
like
on the exact time frame, but yeah, it often can be quite some time before it's diagnosed. Now, for patients who go to their annual physical exam and get their diabetes screening, we will usually detect it well before diabetes. Often we'll detect it in the pre-diabetic stage, and we're able to prevent the development of type 2 diabetes.
To summarize, the comprehensive care that's provided, that relationship with the clinician really leads to a longer, healthier life. I think that's so basic, but yet missed.
Mm-hmm.
But if you could give one piece of advice to the listeners to say, what can you do that'll make a difference in your health and wellness, what would you tell people?
I don't know if it's one thing, but my one sentence line would be move, so get exercise, pay attention to what you put into your body, which includes diet, but also toxic substances like alcohol or nicotine. And then go to your annual physical exam and talk about prevention with your provider to make sure you're updated on all your screenings, which includes labs, cancer screenings, and then vaccines.
Excellent. Mm-hmm. It was good having you.
Yes, thank you.
Once again, this is Dr. Lauren Hall, physician at Union Point Clinic Family Medicine, Mount Vernon. To learn more, visit unionpoint.org.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.